So those responsibilities often fall on the school secretary, and they are often totally overwhelmed. I don't know if you've seen that here in the schools, but we walked into schools and they pull out this drawer that's just a jumble of inhalers, different colors, sometimes some are clean, not so clean, some have names on them, some don't, and they have no clue what these inhalers are or how to use them. Well, this one I think belongs to Johnny, and I think it feels pretty full to me. Those are the kinds of things that we're seeing in school, so it's kind of scary sometimes. But we're happy then to sit with them and say, well, this is the inhaler for this child, this is their asthma action plan, this is how and when you would use this. These are some warning signs that would indicate the child is not doing well. And we'll discuss then in private any key issues that are concerning the child's asthma, and any barriers that might be identified from the school are very helpful for us as well. Provide a copy of the action plan, and that also is a reimbursed visit. We try to make a point of seeing everyone involved in that child's care. So everyone in that child's care continuum is visited at least once. So it's going to be the family, obviously, in their homes, but also there might be a dad who's non-custodial, or dad just sees them every other weekend or once or twice a month. Then we will visit them as well, so they understand how to manage asthma when they have that child. We will visit grandma. Grandma gets a child after school and doesn't understand asthma. Sometimes we'll get referrals on children who are suddenly or urgently pulled into foster care, and we'll get calls from foster parents, and they'll say, we just got this child in the middle of the night, 2 a.m., and found out he's got severe asthma. I have no clue what to do. I have no clue how to treat it. I've got these inhalers. I don't know how to use them. So we try to ensure that each point of care in that child's care continuum is educated about asthma, because what we found was, and what I found also in these mortality review reports, is that if any one of those links is broken, that's where something can happen. If there's any one weak link in that chain. So you can be providing the best care in the home, but if the school falls apart, that's an issue, because the child spends 8 hours a day at the school. Or there were children who did fine at home, at school, they went to grandma's house after school and grandma smoked. And that's where asthma happens. So, you really need to make sure that the entire care continuum is educated about asthma in general and that child's asthma in particular, and what to do for them throughout the course of their day. And as I said, that is also a reimbursed visit for us. Our referral sources are varied. We get referrals from the inpatient population, from many clinics, primary care providers themselves, school nurses, public health nurses. We get self-referrals. Families will find out about us and just call and refer their children or themselves to us. Many referrals come from the managed care organizations themselves. They have what they call asthma registries. They have a registry of their high-risk patients, and they will send us their entire registry, and they'll say, you have carte blanche. Enroll anybody you want off this list. If you can get a hold of them and they agree to it, we're going to pay you for it, because this is a frequent flyer, and whatever you can do in the home is going to be much more than we can provide. Even if they're providing telephonic follow-up, it's not the same as boots on the ground and going into the home and finding out exactly what's going on. So we get many referrals from the managed care organizations themselves. And now there's a brand new children's hospital that just opened up in Grand Rapids. Before it was integrated in one of the other hospitals, and now it's a self-standing facility. And from this children's hospital, we have an agreement with them. They will refer to us every child on discharge. If they've been admitted for asthma, we get a referral for them. And I mean, that's perfect for us, and that's obviously definition of poorly controlled asthma. We're working with the emergency department too to see if that will happen there. Since they opened up, they have been just flooded, just overwhelmed with all kinds of folks that are coming to this pediatric emergency department for the first time. So they're not quite ready to do that yet, but I think that will be happening fairly soon. And that way we'll be getting all the children discharged from the emergency department and from the hospital, and we have just one children's hospital in the area. And that would be wonderful, because that really is our prime target. So we work with the managed care organizations, and we receive authorization prior to enrollment. We have to call them, get authorized, how many visits they will authorize. Our biggest payer is Priority Health, and they will authorize 18 home visits in 1 year. Now, any of you who have ever worked in home care, that's almost unheard of to have 18 home visits authorized. But that allows us to do our 6 lessons, to follow them monthly throughout the year, to go into the school, go into daycare. It covers our entire panel of services. Sometimes we'll need more than that. And some of these families that are just so overwhelmed with psychosocial issues, we'll call the health plan and we'll say, we're just getting into the meat of things here. Would you give us a few more? And they often will. Other health plans, the smaller health plans, will give us maybe 6 or 9 visits, and then we'll have to justify the need for more visits there. Most of the health plans that we partner with are Medicaid plans. I don't know about Maryland, but most children in Michigan are covered by insurance, and if it's Medicaid insurance, it's rolled into a managed care plan. So there are very few uninsured children in Michigan. And they will often authorize after an encounter if there's an ED visit or hospitalization. I said we've signed contracts with 5 managed care organizations. We're negotiating with a 6th. One of the largest payers that we don't yet have an agreement with, but we're just beginning talks, is Blue Cross Blue Shield. And they have said to us that it's going to be difficult for them to reimburse us or to enter into an agreement with us, because they said you don't necessarily have sister organizations around the state that are offering the same types of services to all of our members. So we're working with them to see if they would just let us do a pilot in West Michigan and then maybe help grow some other programs like ours around the state. We utilize just one code. It's called Rev Code 551, Skilled Nursing Visit. And that's for all of our services. That's for the nurses, respiratory therapists, social workers. That's for school visits, care conferences, and home visits. So our sources of revenue, we have an annual budget of just about $600,000. We have 9 staff, equivalent about 7.6 FTEs. We've been able to achieve over $2 million in grants in the past 15 years. We began our direct service arm 15 years ago this July. I'm kind of the grant writing queen. I didn't know a thing about grants before I got into this, and now we've been very successful. And we began engaging health plans in 1999, and that had never happened before. We are the first grassroots asthma coalition in the nation to have a written agreement with a health plan to reimburse us for these home-based case management services. It had never happened before that. And the way we did that was we went to Priority Health, which was the largest payer in Michigan, still is, and they were just absorbing Medicaid in the late 90s. That's when Medicaid was rolling into managed care, and they absorbed a lot of members with asthma, and they were a little overwhelmed at that time. Asthma is very costly. So we said to them, we've got this little startup, this little demonstration project. We've been doing it about 3 years. We said we've seen some really good outcomes. We presented some abstracts at American Thoracic Society Conference and the Quad AI, the American Academy of Allergy, Asthma, and Immunology. We've had some successes there. We've been able to demonstrate some actual reductions in emergency departments visits and hospitalizations and length of stay. So what if you just refer to us some of your most challenging patients, and we're going to case manage them for free, and we'll show you what we can do. And they did. They liked what they saw, and that's when they signed the contract with us. We started measuring everything we did, and if you do nothing else, just measure everything you do from day one. We started doing that from 1996 on. From the very day we opened our doors, we started measuring everything. So by the end of the year, just after 12 months, we presented an abstract at ATS that year, and were able to demonstrate reductions in ED visits and hospitalizations for just 34 children that we had case managed for that year. We started out with 50, and 34 remained in the program at the end of the year. It was not then a standing existing program, so we could not re-enroll somebody. If they dropped out, they dropped out. But for there's 34 children, we saw some significant improvements. And then we went to the hospitals and we said to them, you have the chart for this particular child, and they had 3 ED visits. Can you tell us what the facility charges were for those 3 visits? We didn't want to know the professional fees because that was a whole other ballgame. What did it cost for that visit from the hospital standpoint? And they gave us all those figures. And what we were able to establish was a reduction of $55,000 from one year to the next for 34 children, using themselves as their own control. So the day they signed the consent, and from that day 1 year prior was the pre-test, and then 1 year post was the intervention era. And we compared those two years and saved $55,000, and that's what we took to Priority Health. And we said, not only are we reducing utilization, we're saving money, and we're improving lives, and we're improving quality of life. And that's when they came on board. And when we got Priority Health on board, then we started going to other health plans, and we said things like, well, Priority Health's on board, and now we've got some members of yours, and how about signing with us? In one case, we just started getting referrals on a smaller health plan. I didn't have an agreement with them, and I said, well, you know what? Let's just start billing them, see what happens. Well, they started paying us. And then they called me up once and they said, well, Karen, maybe shouldn't we have a contract? Oh, sure, let's do that. So we entered into a contract. It's kind of easy when you're just this grassroots asthma coalition, you can be naive, and we were. So we had a contract, and then the others sort of fell into place after that. And as you saw, the reimbursement from health plans is about $200,000 a year, and that covers a third of our operating budget. The remainder of that comes from grant dollars. So our outcomes include fewer emergency room visits, fewer hospitalizations, lower overall costs for asthma. This was a study that we were involved with. We looked at the children that were enrolled in our program versus children who were not. Now, we decided very early on this was not going to be a randomized control trial. We just couldn't in good conscience do that. We couldn't get a referral on a child and say, well, we've got this program, we think that works, but we can't enroll them because they're going to be in the control group. So what we did was we pulled a retrospective control group, and we just pulled children who had asthma from the children's hospital. We pulled their records, and we compared them to the children who had been in our program, 45 of them in our program, 39 in the control group. And we matched them for age, for asthma severity, so they also had asthma severe enough to warrant an ED visit or hospitalization. We matched them for socioeconomic status based on zip codes. And what we found was that children in our program actually got better from 1 year to the next. You can see the reduction in ED visits, hospitalizations, days hospitalized. These two were significant. The children in the control group, you can see, got worse from 1 year to the next. They had more visits and more days hospitalized. And then the final column is the difference between our cohort, our children in the study, and the control group was highly significant. So that to us proved that it was indeed our program that was making the difference and not just the nature of asthma in the state. They had a home-based case management model for 10 years and were not getting a dime for it. They were not getting any reimbursement for it. So about 3 years ago, they convened a summit, and they had their payers come to this meeting. I brought my payers from the west side of the state, and my payers talked to their payers and said, okay, this is what we've seen. These are the benefits that we've seen. We really think that you should step up to the plate and start paying these folks because we have seen the tremendous benefit that this can bring to our members. I think it will do the same for yours. And then at that meeting, someone actually said to them, who is going to raise their hand here and start committing to reimbursing them? And there were a couple folks that did. So they are now getting reimbursement for the same types of services they were providing for 10 years. It just hadn't happened before that. And now they also took great pains to make sure that they were exactly replicating our model as is. On the other hand, in Washtenaw County, which is the Ann Arbor area, which is where the University of Michigan is housed, they had a school-based program. And Priority Health acquired some health plans in that area. So they went right to Priority Health and they said, you're paying the Asthma Network of West Michigan, would you pay us for our school-based program? They said, we really believe in the home-based model. So if you replicate what the Asthma Network of West Michigan is doing, we'll pay you for that. And so they came over, we gave them technical assistance, helped them create this case management, home-based case management model in the Ann Arbor, Ypsilanti area, and they are now getting reimbursed for the same types of services there. And actually, we're looking at our 3 communities, and we're going to be comparing outcomes between our 3 communities and other counties around the state that don't offer case management to see if there's a difference. So case management results, we have found that an intensive case management program can produce significant positive outcomes in a low-income population of children with moderate to severe asthma. The same program can be cost-effective. Great numbers of community members can be educated through an effective community outreach program. This program can be replicated in other communities, and this program can enhance the services of a patient-centered medical home pilot targeting children with uncontrolled asthma who are covered by Medicaid insurance. That's sort of lessons learned over the past 15 years. And just as a side note, this is actually in Dr. Graham's practice in Atlanta. You might wonder, well, the same kind of thing work in a clinic-based setting. And he, again, has the largest pediatric pulmonary practice in Atlanta. They employ 2 certified asthma educators, and they conduct sessions, and they bill utilizing asthma self-management education codes. They've obtained reimbursement now from 3 Medicaid providers in Georgia, and the services are so well received that it's likely to be rolled out to all their patients. So these educational services have also generated very high levels of patient satisfaction. So they really like what they see, and the patients like what they're hearing.